All right, we're recording. Yay. And I apologize that I'm on my phone. I had a Chromebook nightmare 7 minutes before. Um, just making Jennifer was making a face like I can't hear you, so I was making sure my volume was on. So I just want to ask a quick question. Do we have EMS staff on?
I don't see any EMS staff here.
So I may just tweak this a bit just to let you know, because I think with the audience we have, I still have plenty to talk about. Okay.
Right. Yep. And we also will be using this as a tool for them. We can send it
Yes.
out to them. So, yes.
Okay, just wanted to ask that. Okay. Hi, everybody. I'm Jess Tilly. Comes up Jessica was the only name my mother would yell when she was really mad. So whenever I hear it, I jump. So when Jennifer just said Jessica, I was like, oh, what did I do wrong? I have been working in harm reduction for 25 years, which gives my age away. I like to say I started when I was 4. That's not true. I came in at 18 as a very chaotic user, going to a very privileged school on full scholarship. And um, I tell people trauma was my gateway drug. I jumped right to heroin. There was no marijuana. And the first time I used, I felt like I could be in my skin and I could be present without actually having to be present. I say this because it's shocking for people to hear that I say heroin saved my life, but it almost took my life. Which is why I do the work that I do to help people that may be in the position that I found myself in, when that position was behind a closed door, alone, full of stigma, and pretty sure that I was going to die alone. And I knew that I had self-worth. I have a friend staying with me that has a phone in this room. I apologize because I don't know how to shut off her ringer. So finding myself at 19, I found harm reduction. I found a syringe exchange in Massachusetts, by a professor explaining to me what syringe exchange was. And I found 2 things that day. I found that I had realized that I had a service provider treat me as a human for the first time in over a year, and that I didn't have to lie to procure services, because that's what traditional service providers do. They make people lie in order to get services. And 2, I found what I wanted to do the rest of my life, which would take up the rest of this webinar if I explain to everybody what I've been doing for the last 25 years. So currently, I'm the executive director of the New England Drug Users Union, which is 67% now abstinence-based people in recovery. And I say that first because people think that all we do is, advocate for people to use drugs, and we don't. We advocate for people to have basic human rights. Um, I'm also the co-founder and co-director of HRH 413, which is a grassroots harm reduction agency that runs outreach teams through Berkshire, Hampden, Hampshire County, and we also respond to overdoses where 911 cannot or will not be called, and we'll be talking about that later in this talk. That's like the very shortened introduction. I always feel like I'm taking up way too much time talking about myself, but I just like to identify and kind of give testimony to who I am and why I do this, and also to say that I identify as someone who uses drugs because it takes away that stigma. You don't know if I used 10 minutes ago, you don't know if I used 20 years ago. I will tell you it's closer to the latter. So without further ado, I want to thank Christine for these wonderful slides. I had just switched from a Mac and could not make slides to save my life. So Christine jumped in and saved my life. So today we want to cover, there's 3 main points to today. And I think I kind of talked about them all when I introduced myself. People who use drugs are in the midst of an apocalypse. There are certain drug trends that are happening now that are absolutely killing people, and I know fentanyl being the highest one. So we'll be talking about drug use trends, breaking down myths. As I'm sure most people have heard the fentanyl myth, that if you touch fentanyl, if you stand in the room with fentanyl, you will die. That's not true. We'll be talking about the real costs of treating somebody in ER versus the cost of administering naloxone, or the actual cost of 1 bottle of naloxone, which is Narcan. We call it, I use a lot of IMs, I call it naloxone. And we'll also be going over potential scenarios and tools to work through them. with EMS. And also I'm going to talk a little bit about service provision today too, because we have a lot of service providers in the room. And, and lastly, we'll be talking about drug-related stigma. And I'll be honest, drug-related stigma is the biggest killer. It kills people more than fentanyl. So I'm going to jump right into like drug use trends. As we know, we're seeing fentanyl, and I'm going to discuss, because what I do with work with both NEUU and HRH 413 through our outreach teams is we cover, like I said, all 3 counties and up into Vermont, New Hampshire and above. 2 of the main drug use trends we've seen are a lot of people switching over to cocaine because of the fentanyl, and there was a lot of misunderstanding that people thought like people are going to put down fentanyl and pick up cocaine. The reason that we've seen a rise, and at least this is me being on the front lines of cocaine use, is that a lot of people during the pandemic did get onto MAT, being either methadone, Suboxone, Vivitrol, and what we usually see is when somebody's in their first year who hasn't actually entered into sobriety, is they will switch over to cocaine. The danger in this right now is that we're seeing so much fentanyl and cocaine. So somebody who may not be necessarily opiate naive has now put down what they consider to be fentanyl. They're on MAT, they're on Suboxone, they're using a drug that they don't expect to actually have fentanyl, and we're seeing a lot of overdoses happen this way. Primarily, more so among recreational drug users, like because our overdose team has covered college campuses, we were seeing a lot of recreational cocaine users, weekend cocaine users who were absolutely opiate naive, meaning they've never touched an opiate day in their lives, doing what they expected to be a stimulant and having an opiate overdose. Thankfully, because we had been up on the college campuses for so long, we were able to flood the campuses with naloxone. This leads us to why people weren't calling. This is our second, I was going to say my second big drug use trend we're seeing, which is, and it will be discussed later on in a little bit more detail, is that people are terrified to call 911. I was going to, well, actually, I'm going to tell you this story later on. Something happened yesterday that is the main reason I wanted to do this talk today. So people are afraid to call 911. And the reason they're afraid to call 911, even though we have a good Samaritan law in this country, in this state, I'm going to say we don't have it everywhere in this country, is why we're doing this talk today. People have had horrific interactions with EMS. That's not to say that people haven't had wonderful interactions with EMS, but part of what we do as our outreach teams is we take report backs because we're distributing naloxone. So we hear what happens when naloxone is used and 911 is called. And as a harm reductionist, when people ask me what is the most important thing about responding to an overdose, the first thing I say is breathing for the person. Well, now that we have fentanyl, I say hit them with naloxone first, but it's 911. We say call 911. You have to have somebody on the way. How do you get people to call 911 when the last time they called 911, they were arrested, they were berated, they were treated as a second-rate citizen, and they were literally like spat upon, like all but spat upon. I had somebody had a spit guard put in their mouth, but that's not being spat upon. So this is a challenge because people will hesitate, bystanders will hesitate. So the problem that happens a lot is that I shouldn't say a problem. What happens is naloxone ends up being in the hands of the bystander, and what we have seen happen is that people will give too much naloxone. So we really stress, people might have heard, like, in the age of fentanyl, hit them hard, hit them quick. We used to recommend that you wait 2 to 3 minutes, do rescue breathing. The most important thing, even with fentanyl right now, is not panicking and staying calm. And I know it's so hard to stay calm when you're watching somebody overdose, but administrating naloxone slow. You would think that EMS understands this. They don't. They use it as a punitive measure so many times. Again, I'm going to give a scenario later on that I witnessed myself that was horrific. Um, it's very simple. Too much naloxone leads too fast to too many problems. Um, I'm just going to ask whoever's controlling the slides to kind of move ahead to basic harm reduction. There we go. Sorry, I thought I would be controlling them. So this may sound funny, and again, this is being recorded for EMS, so I wasn't going to talk about this, but I will. Basic harm reduction. We would think EMS understands basic harm reduction, and I hope I don't sound really snarky and snotty saying this, but when I came into harm reduction in 1996, I had an interaction with EMS shortly thereafter. I assumed when EMS came into my home that they would understand harm reduction because I was very naive. And what I encountered was a bunch of angry, and this is hard for me to talk about because I come from a family that's EMS and police. Um, Police officers entered my home first. We had somebody on the floor who was overdosed. This is before we had naloxone in our hands as bystanders. Person had already been out for 4.5 minutes. EMS came into the house. Now I had somebody who lived in my home who was known for schizophrenia. And so they came in and they looked at him and realized he was okay and said, "Oh, we don't have anybody going crazy this time. It's somebody, a junkie." Those were the exact words. And I'll never forget it because these were the men that I thought were going to save my best friend that was laying on the floor dead in front of me. And so I naively started to try to educate them about harm reduction. And I ended up with handcuffs. I ended up being cuffed. And even though I wasn't being belligerent, I wasn't arguing, I was cuffed and I was led into the other room. And thankfully, my best friend survived, even though they were without oxygen and we'd been breathing for them, but they had been unresponded. They were technically, they flatlined twice, but they lived. But all it would have taken was a few more seconds, and she wouldn't be with us today. So I like to keep that up front because there were simple harm reduction strategies, and she was what we called loading on and given way too much naloxone. So she was very sick, and that was a punitive measure. So there's very simple strategies, very simple harm reduction strategies. And this is what we ask EMS to talk to people about when you have been somewhere. You have been somewhere where there's been an overdose. We don't want EMS to be judging. We don't want EMS. People who use drugs don't need, we've already got so much stigma coming at us from all angles. We look to people like the police, like EMS, paramedics, EMTs, to people to be protecting us. So, there are basic common conversations you could have with somebody after they come out of an overdose. And things very, very simple. I mean, like, I've got the slides up, you can see, like, these are things we know as people who work. And I don't know how many people actually identify as harm reductionists who are listening, but this goes for service providers. I heard a lot of people say they work in addiction, and we talk about language too, because even the word addiction is a little, I mean, it's something I grew up saying, and I still have to correct myself, and we're going to talk about language later on. But, working with people who have substance use disorders, you may have somebody that comes in and talks to you, and they don't want to stop using. And so these are very simple things that you can talk to somebody about. Biggest one, number one, never use alone. I can't tell you how many overdoses, people who died of an opiate overdose would still be with us today had they used with somebody in a room with them. You can keep somebody alive for 2 hours by breathing for them. Doing tester shots. I work, well, we do an underground line that isn't never use alone, but part of what we do is we respond to overdoses where people will not or cannot call 911. And so I am the person who is on the other line when somebody is using alone. And we have a system in place where if the person should overdose, 911 will be called. We try to have somebody intervene. Doesn't always happen that way, but I've got to say, more and more people have been using tester shots. It's something we talk about in harm reduction a lot, and a lot of times people don't use a tester shot. A tester shot is a tiny bit of a regular dose. It's very important. People who are in withdrawal, I've had participants tell me, like, I don't want to do a tester shot. Why would I? I'm sick. And, like, there's a difference between sick or being 6 feet under. You know, what do you find to be better? And I used to not, you know, part of harm reduction is meeting people where they're at and positive changes. But when it's so on the line right now where we are, we're in the midst of this devastating fentanyl influx into our country. I can't afford to be very lackadaisical when I'm telling somebody. I can't afford to not tell them what they should do. And I've had a lot of harm reductionists push back on me like that. But as somebody who has reached my age, as somebody who's an opiate user, I feel comfortable telling somebody, please do a test. I don't point at them and say, do a test, just please. Going slow, it's so important. People don't realize that when one injects quickly, it's obviously, if you're injecting, it's going to hit your body harder, quicker. Injecting slow, you can get a feel for how the strength of the drug that one is using and stop. And we've gotten a lot of report backs where people could tell within, the first 5 cc's that it was way too strong and they were able to avoid an overdose. Simple things, again, talking with EMS, where we've discussed, I've sat with many EMS workers and I said, what do you talk about when somebody comes to you? And, if you notice, and this is why, this is so important, why I implore EMS not to take people's syringes. We testing have seen an uptick in HIV and Hep C. One of the common report backs we get is that their syringes were confiscated either by the police or by EMS in the midst of COVID. This is a death sentence for people. I'm not saying death sentence like HIV or Hep C, but you're literally, taking away somebody's syringes, like they're already using alone. You're placing them in a place of high risk, beyond high risk, and you can't do that. Like in Massachusetts, syringes are legal to carry. As a Pharmacy Access 2006, we can buy syringes in a pharmacy. It used to be that you had to carry a card. It is frightening how many EMS and police do not recognize this rule or have never heard of it. Sometimes it's done punitive measure, but a lot of times it's like they really believe that people do not have the right to carry a syringe. If you notice somebody only has one syringe, and this is why I'm a firm believer that EMS should be providing clean syringes for people. Talking about how to bleach syringes. I know it sounds very like old school 90s, but we still give out bleach. And simple things, because we have such an uptick in endocarditis right now, MRSA, explaining to people why they should clean injection sites. Beyond alcohol, I'm a very firm believer in soap and water is the best thing you can use. I'm going to talk a little bit about buprenorphine and inductions with ER and EMS. So there are great things happening across this country right now where EMS is actually starting to do inductions. I know we're not at a place here in Massachusetts. I wish we were getting close, where EMS can actually begin the induction. There's so much data showing that right after an overdose, whether it happened in the ER, whether it be EMS, when somebody who's come out of an overdose, and usually they're going to be in withdrawal. As we know, buprenorphine causes withdrawal, floods the opiate receptors and knocks any opiate out. Really uncomfortable place for somebody to be for 2 hours. They're more willing to get onto MAT at that point. And you're also, by having somebody who is with you, and this is even walk-in clinics. If somebody walks into a clinic in withdrawal, we should have the right to medicate them that day. I know it says buprenorphine here. I'm a firm advocate of methadone, because we can give people methadone when they are in withdrawal. When they're not in withdrawal, if they walk in that day and say, hey, I haven't used in 6 hours, I need to. What we're seeing right now with fentanyl is that it's taking a super long time to induct people into buprenorphine. We have to I do work with few providers, but people have to be microdosed, and in order to, because they're going to precipitated withdrawal. What methadone allows is the person to be medicated that day. But EMS are the first responders, so they're seeing somebody right after an overdose. What would be a wonderful harm reduction technique is to allow them to take this medication and what we call fast tracking somebody right on. My personal opinion, but in the midst of this opioid epidemic, I believe MAT is going to save us. The next slide is going to just show a couple of examples of EMS inductions and, just kind of give you a few ideas of how this could work. I think it's really important that EMS partners with outreach. And when I say outreach, I mean partnering with a harm reduction outreach team. One of the things I did when I was program manager in Cambridge Needle Exchange, because we had such pushback between EMS and the police, is we started holding meetings where, and it was like a meeting nobody would ever imagine happening. We had paramedics, police, and people who use drugs sitting in the same room. In the first 3 meetings, I think two police officers showed up and me. And slowly it started to build. And what came out of that was a lot of judgment, misunderstanding, and myths were laid out on the table, and strong bonds came out of that room that still exist to this day. And because I still keep in contact with many of the people. Unfortunately, a few of the people who use drugs are no longer with us, but 2 of them went on to actually become recovery coaches, and one is now a counselor. And what we began to understand is that police don't want to arrest people who use drugs. People who use drugs don't want to be arrested. So how can we come to a basic understanding and respect one another? What the police want, what EMS wants, is to keep the public safe. People, there's, and I'm going to bring it up later about there's a big misunderstanding that people who use drugs don't care about their health, don't care about society, will leave their syringes wherever, like everybody sees the small white child running across the I think Amphar did this commercial, I shouldn't say it, but running across the playground, and then there's the big syringe and her foot's going to come down it. What a way to it's such drug porn. What a way to play on the fear of society. If I saw that, I wouldn't let my child go. I'd be afraid every time I saw a person who uses drugs. It's horrific. And this was put out by an agency that says they support harm reduction. And again, it wasn't done to be mean. It was done out of ignorance. So, by having EMS talk to people who use drugs, work with outreach, you're going to find those hot spots. You're going to find those neighborhoods where people need help the most. Leave Behind naloxone is a wonderful, we're trying to get it started. It supposedly was supposed to be happening in Massachusetts. It's not. It's done by people like myself who do post-overdose. It's very simple. Leave Behind naloxone is the idea. It can reduce burden on first responders. It increases peer reversals, of peer being the person bystanding, person who uses drugs, a parent. The cost, it's very cost effective, it's most impactful. And naloxone distribution, biggest thing I think I'm preaching to the choir here, it does not enable people to use substances. Anybody on here or anybody listening who has heard about a naloxone party where people who sell drugs are giving out naloxone and selling drugs? Now, I will be honest, we work with people who sell drugs who don't want people to die. They do give out naloxone, just as they give out, sterile syringes. This is not to increase clientele. This is because people who sell drugs are usually people who use drugs who are just trying to support their own habit. And even people who don't use drugs that sell drugs, they're humans. They care about people. Again, media has made people who sell drugs out to be the devil. I truly believe people who sell drugs, who are bad people, were bad people before they were selling drugs. So access to naloxone, it leads to reduced overdoses. It's very simple. If you have naloxone, people are going to live. It's legal to leave naloxone behind. I just had this argument with somebody. It's not really legal to leave naloxone in the middle of a park. Even though it doesn't hurt people, we don't want a child picking it up. It's just bad optics. And it's legal for anybody in the state of Massachusetts to carry naloxone. I get calls weekly asking, do I need a prescription? We have a standing order. We're able to give it out. Very simple to use, very simple to train people to use. And so in Massachusetts, that's what it was. In Massachusetts, EMTs, a person has the right, once they're in you know, a person has the right, even midway to the hospital, to say, I don't want to go. What happens again, and this is why people are dying, is that people are terrified to go into the hospital. As we know, many people who use drugs have secondary infections. Again, I mentioned earlier, being like endocarditis being one of the #1 killers right now in Massachusetts. Um, we've heard horrific stories of people having PICC lines ripped out of their arm because they're in withdrawal, being literally kicked out the door, being called every name in the book. Um, I'm sure everybody can understand why they would not be in that position. Never mind withdrawal being on top of it. Even if somebody is already on MAT, it can take days to get your medication. So this is why people, you know, when we hear like, oh, you know, quote unquote, junkies don't care about their health, they won't go to the ER. There's reasons they're going to the ER. They're terrified. That to me is the biggest disservice we're doing as providers. We should be able to do warm handoffs where somebody feels safe in a hospital, where doctors are not condemning people for a personal practice that they're doing. So these are just the leave behind laws. I love this idea. I think it's wonderful. Again, just like reminding people about the naloxone law. Again, it frightens me how many people don't know about the naloxone law. And you know, I think it's just due to the fact that people, we had naloxone for so long, and people, laymen, were, it's very shocking to know that we had this tool and that we weren't given it earlier on. I want to talk about myths. I know I'm running a little bit on time here. Well, I guess we have some good time. Breaking down myths. So I started, this is going to be the fentanyl exposure, but I started maybe 2 minutes ago talking about the naloxone party myth, and I think this is a good lead into other myths about people who use drugs. So I'm sure there's a few that are saying, she started to talk about naloxone parties. What are those? So a story came out a few years ago. It was just like urban legend about people who were selling drugs and then giving people naloxone, reviving them, that there were these parties happening with people in a room together, like 10 people. And so they would revive, and then they would buy more drugs, and they would inject, and they would overdose. And then the person selling would, you know, hit them with Narcan. And this was going on in a big circle. Like, physically, that's not possible. Second of all, anybody who has been like Narcan will tell you, it is and myself included, it is the most horrible experience. You never want to go through it again. It's instant precipitated withdrawal, and that you can't. People, that's one of the biggest things we tell people. Because you have a blocker, you do not want to inject again. You're not going to feel those effects for the next 2 hours, and you are at risk for overdosing by just piling more on. So that is, I didn't get to put that in the slides, but that is a myth I wanted to dispel. It's not true. Fentanyl, as we know, we see so much in the news. One very most important, you know, that, I guess it's not the most important. I guess I'm saying it's most important to me because I hear about it all the time. Marijuana, as we know, is here in Massachusetts legal. Fentanyl cannot be laced. I mean, marijuana cannot be laced with fentanyl. There is a synthetic plant like that would be, you know, used for spice, or K2 marshmallow plant that looks like marijuana, but not really. Anyone who's seen marijuana, if you saw it, you'd be like, that's not marijuana. The way it was explained to me is, you say it in 2 sentences. People that have been arrested that said they had marijuana that was laced with fentanyl, say the sentence to yourself: I thought I was smoking marijuana. Say the second sentence: I thought I was smoking marijuana, officer. So if that can make sense to people, because what you're saying, the reports that we have gotten back and what we've seen from police reports, it didn't look anything like marijuana. The person being arrested who had overdosed knew it wasn't marijuana, but told the police it was marijuana because he knew he wouldn't be charged. And we actually have report backs that came back from participants, and we're like, that's clever, but now we have a huge rumor in Massachusetts about marijuana. Contact with fentanyl. Great video came out. I wish I could have shared it. Well-known harm reductionist, former DA in Missouri. He's amazing. Did a video, and he's opiate naive, where he actually had a chemist with him. They took fentanyl, rubbed it into his skin, The skin is a blocker. Skin is, and I've argued with EMS workers about this, about supposedly there's a place in your armpit that can, you can enter, and if you can get naloxone, I mean, if you can get fentanyl to your armpit, more power to you. I don't know why it would be there, but touching it, it's not going to happen. The skin acts as a barrier. It will not pass. You could have a cut on your hand. It may enter, but hopefully you're wearing gloves. If you're responding to an overdose, you should have gloves on. You should have a mask. It's not enough powder. We've all seen that penny with a little bit of powder next to it. That, there's so many analogs right now with fentanyl that originally, yes, that is true. I believe it would take 10 barrels of fentanyl to kill all the United States. That's in its pure form. We're not seeing fentanyl coming through in a pure form like that. What we are getting is broken down. It's been cut. It's been diluted. So, but the media putting out visuals like that give people the idea that a tiny bit like that touching it could kill you. Now, it's different if we're talking about modes of administration. That's a completely different story. Forms of fentanyl being resistant to naloxone, not true. I work with drug checking. Every day we're seeing new analogs. We're seeing new research chemicals coming out, synthetic opioids. It's constantly changing, but as of right now, fentanyl is more potent. It requires more doses of naloxone. That's why I said in the very beginning, we say hit them hard. You don't want to cause somebody unnecessary uncomfortable, because the more naloxone you give them, the more blocking effect is going to happen, the more withdrawal is going to happen. But again, like I said, withdrawal versus loss of life, anybody will take precipitated withdrawal. So important. There is no problem with first responders being overly cautious around fentanyl. I cannot tell you how many times I've given this talk and somebody in the audience raises their hand and says, but what about so-and-so from so-and-so department that, overdosed? This is very true. All of the claims, every claim in the United States right now that has been investigated has not been founded. There is no finding. In fact, they actually found out that the officer who filed the report, it was found that he was actually using. What we're seeing are panic attacks, people having panic attacks, because I don't blame them. If you're told if you touch this powder, you die, so it's mimicking an overdose. There are the videos that are out right now where I don't know if anyone's seen the one where the police officer is like, oh no, I'm overdosing, I need my Narcan. You don't talk during an overdose, you're overdosed. So again, this is why first responders are being terrified. They've seen all of this. What this has resulted in is people dying. There was a situation that happened out towards the Cape, maybe about 2 years ago, where EMS had arrived. There was a bystander who had Narcan. Police had arrived. There was a bystander with Narcan. They would not let the bystander use the Narcan. They were waiting for hazmat suits to show. Their department had just gotten hazmat suits. Everybody was told to stand back because they could die if they went near the fentanyl. Who died? The person who overdosed. That's the only person that died. And that to me is a crime. There was no reason for a 21-year-old person to die when there was enough Narcan to save about 10 people. So that's what we're seeing happening. I can't tell you how many stories have come back to me about EMS arriving, not having, or telling people they can't use Narcan because they're afraid of touching somebody. There were these gloves that were put out that was like totally to prey upon EMS workers, where it was like fentanyl resistant glove. It is, I think, of all the myths, this is the most important, that we break this down and we educate EMS, again, because they are the first responders, and it's their job to save people. And it's like I've told people, fentanyl isn't going to jump up and shove itself down your nose. Don't be afraid, wear a mask. And So as we lead into what are the real costs, um, we used to talk about when Narcan, when there were pilot sites for Narcan, and there was such pushback, like we were told that Narcan shouldn't be in the hands of bystanders, that this was medical, it shouldn't be in our hands. Um, Very simple statistic I used to give people was an ambulance ride. An ambulance ride, and we know we don't have it on here. I have, you can look at, I could read them to you, but I hate reading from slides. Just examples of costs, but really the most basic cost that I would share with people is an ambulance ride, and anybody who's been in an ambulance for any reason can tell you this. $1,000, 1,500, and that's not if that's just the ride. That's not if they use oxygen, if they have to administer medication, versus naloxone, $150. And I'll be honest, I am naloxone. Is we get it anywhere from $1 to $10. So if you go to the next slide, which at the very bottom, I think that of all the data is the most important. If you look at what paramedics per hour, dispatcher, the ambulance cost, the insurance, naloxone, I mean, that's a couple grand. And it goes up to 1,500, 2,000 versus 150. Even the most hardened of Republicans, I've been able to sway at the end of the day with that statistic because it's cost effective. All right. I'm going to jump over to potential scenarios, tools to work through them. I'm going to get into outsourcing to outreach in a second. Jennifer and I had talked about scenarios, and I'm going to try not to cry through this, but I think it's very serious. So one of my best friends and a harm reductionist, who's amazing, who started one of the projects that I built my project and used as a model, Red Project out in Grand Rapids, Michigan. John Lemaire, his name is, and he is one of the harm reductionists that does the work on the ground, boots to the ground, has worked hand in hand with EMS. Everything I talked about that I've done, he has done as well. So 3 weeks ago, John's wife ends up with COVID. And I should mention that during COVID, John, who had been on MAT, was removed from the clinic because they started to cut down the amount of people that could attend the clinic. This was also happening. He had moved to Louisiana. And so he's without methadone and he starts using again during the pandemic. So wife has COVID. John starts not being able to breathe about a week and a half ago. Terrified to call EMS because he's had multiple interactions with them that have led him to jail. Whether they searched him and this is over the past 20 years, they searched him and found syringes on him and they were illegal at the time. And no reason to search him. I should add, they had the police search when they got there. So he's scared. He can't breathe. He assumes he has COVID. It gets bad enough that his wife forcibly puts him in the car with COVID, having COVID herself, drives him to the hospital. They triage him in the parking lot. He says, my wife has COVID. They don't test him. They see his track marks and they say, oh, we know what this is. We're not giving you any drugs. They send him home. John didn't want drugs. 2 days later, John sits up, says, I'm going to die. Turns to Jenny and says, I'm going to die. I know it. I just dreamt I'm going to die. She looks at him. She sees his eyes, says he looks like he's between the veil, calls 911. They come to the house. They are horrific to him. They come in hazmat suits, which we understand because there's COVID in the house. And they start making comments about, what do you want? You want drugs? What, you didn't get your drugs today? John, turns out, is sepsis now. Keep in mind, he was at the hospital 2 days before. So they take 11 hours in the ER. They put him in a back room. They ignore him. By the time they get to him, he has blood clots in his lungs. And a blood clot breaks off, goes to his heart, he dies. So John's no longer with us because of EMS and the way that people who use drugs are treated in this country. And I'm trying not to cry. Like, I just got this call last night But what's heartbreaking is this John is not the first story. He won't be the last. And it continues to happen in this country. Um, I wish I could, say things like John was treated wonderfully and they identified the problem when they had him in a parking lot 2 days before. But no, because they saw track marks, they assumed everything was drug seeking behavior. So that's a real scenario. The tools to work through it: treat him like a human being, treat him as you would treat anybody else, treat him as you would treat the grandmother coming in who just broke her hip. Um, one of the worst things I ever witnessed, what happened in a park in Boston as I was an outreach worker. I had just Narcan somebody. They were standing up. They were alert. We were actually making plans to bring them to detox. EMS 911 had been called. EMS shows up, push him to the ground and Narcan him and laugh and turn to me and say, watch what happens when he don't think he'll use dope again. Guess what? He is going to use dope again because now he's not going to detox. Now he's really sick. It's very easy to administer slowly to not bring somebody to that full withdrawal. This young man sat up vomiting, like it was horrific. Thank you, someone saying my loss. I was told myself I wasn't going to cry, but I thought I owed it to John to share that story. And we hear this quite often: people being given naloxone as a punitive measure. Giving somebody naloxone will not make them stop using. I've had parents call me and say, could I use the naloxone kit? My son is nodding on the couch. If I hit him with Narcan, will it make him sick enough that he'll stop? No, it'll make him sick enough that he's going to go out and procure more drugs and possibly overdose again. I wish it was that simple. I wish we could just Narcan everybody into recovery, but it doesn't work that way. Tools to work through this: again, that situation that happened in the park, the EMS team had just listened to the outreach team. And that's why we're going to talk about like outsourcing. And I understand. We as harm reductionists, everybody in the audience right now, our compassion fatigue, our burnout is absolutely astronomical right now. I found myself as a harm reductionist saying, I can't do this. I'm done. If I get another call that somebody's dead, I'm walking away. Anybody out there in the audience that knows me knows that's never going to happen. I'm never going to walk away. But there's a way for us to lessen the load, and outsourcing is one of those. Like, outsourcing is where, EMS, and I know there's been, this is why I turned to Bopsy and I'm like, please, you could do this. Outsourcing is essentially like a post-overdose response team. It's connecting, it's doing warm handoffs with people. A lot of times people are going with EMS, they're going to refuse transport because of the reasons I just told you. If you have a consistent, sustainable team of people that the EMS can reach out to, and that's everybody here that understands, that is not going to pass judgment. Like, our outreach teams are known for being compassionate, for going with people to appointments, meeting them at the door when they get out, going to the next appointment. That's outsourcing. That's like recovery coaches. We have a wealth of recovery coaches in this area. I think for a long time there's been like this ego. If we flip to the next slide, you'll be able to see, like, kind of give us some ideas of what outsourcing can look like, from like the least intensive to the most intensive. It's it's simple. It's like, connecting overdose survivors with recovery coaches, leaving naloxone behind. And this is also something EMS workers can do. We all know, or I said, I was going to throw Stephen Murray out there. We all know Stephen Murray. Like, we can all know somebody like Stephen Murray. People can become Stephen Murray. Stephen's going to kill me when he hears this. It doesn't take that much to be humane and to take the extra 5 minutes to maybe get to know your local harm reductionists. Where, I have relationships like that with the police, where they will call me and say, hey, I have somebody who's pretty resistant to like talking to anybody else but somebody who understands, who's been there, somebody who identifies as a person with lived experience. Can you talk to them? And absolutely, I always will. And that's that's why we have a large team, because there's way too many people for me to talk to alone. Why outsource? Simple enough. Current system doesn't work. We're dealing with just laughing. We're dealing with inadequate, broken systems. The treatment system does not work. We'll never have enough beds. Traditional traditional service provision is not working. If it was, we are seeing in Massachusetts, our overdose rates have gone down, among white people. And I'm sorry to say it like that, but I grew up in a neighborhood where people of color died daily and nobody cared. So yes, we have these great grants. We've got Mass Heal. We're going to reduce overdose by 40%. In what neighborhoods? It's happening in suburbia. It's not happening in the neighborhoods where people's children are been dying, where the system has failed them since the day their child was born, when insurance didn't cover the birth. I'm not going to go off on a tangent, even though I went off a little bit. This is what the reality is. Our system is not working. So we need to try different approaches, whether that be safe supply, whether it be safe consumption spaces. This is where EMS can really come in, and we do like a bottom up instead of a top down approach, and we meet people truly where they're at. And it's not always just, again, I've been really focusing on substance use disorder. We're also talking mental health, EMS, domestic violence. I could give a whole talk about domestic violence and how EMS the way things currently are done, should be doing it a lot differently, and we wouldn't be seeing repeat. I think that's one of the biggest issues why EMS workers get a little like snarky and mean to people who use drugs. They see the same faces over and over. There's a way to fix this. There's a way to like intervene, and you might not see the same people over and over. And it doesn't mean that they overdose. It means that they're going on to live the most productive life they can live. Getting follow-up on your patients is one of I know for me, I say participants, but when I see somebody 6 months down the line, and maybe they didn't stop using, but now they're housed, or maybe they didn't stop using, but they've got a job, or maybe they did stop using, now they got their kids back. And it's not an ego thing. I never look at it as an ego, although sometimes it does be like, there's a reason when I don't want to go on, I'm still here. But it matters because I'm that conduit that allows this positive change to happen. Like or we, the team that I work with. So it makes my work impactful. I know it's sure as hell is going to make EMS's work impactful when they see people and they know that they made a difference. On to my favorite topic, drug-related stigma. Stigma kills. That's it. That's all I can say. Stigma kills. The reason I mentioned in the beginning of this talk that I wasn't I like to tell myself at the time that I wasn't the stereotypical, because by the time I was using, I believed the media when they told me what a drug user was, but I knew inside that I wasn't that person. I knew that I wasn't going to rob my grandmother. I knew that I wasn't, living in a gutter. I was doing sex work. Yes, I was, but I was a responsible sex worker, and I was going to Smith College. The reason I said that is that stigma almost killed me. I was behind it. Somebody found me. And the reason I was behind that door alone is I was afraid to hang out with other people who did drugs, because I was afraid that if I did, that I would really live up to what society thought I was. And as I got to know those people who did drugs when I started working in syringe exchange, they didn't fit what society was telling me. So, kind of like, as I said about people who sell drugs, people who use drugs, we hear that people, like, oh, the drugs made me do it. Yes, drugs, like the desperation to get and procure drugs, people may steal from their families. But I truly believe people who are inherently not good people were not good people before they did drugs. Anything else is just based in trauma, necessity, and need. So language matters. That's why, I wasn't, because I say addiction all the time. Trust me, I get yelled at it. I don't know when the current language changed, and all of a sudden I was saying addiction, and somebody said you can't say that anymore. And using person first language, people who use drugs, I still struggle with that, and I understand when people struggle with it. It's much easier to say drug user, drug seller, but people first. We use that in mental health, using it now, framing the conversation. I can't tell you how many times that I've been on the other side of the desk more lately, like the last 15 years, as an advocate sitting with somebody where you have 2 minutes to make a connection with somebody, and when you use a word that's demeaning, judgmental. You may not even mean to, but if you're using your own judgment and you're what you want for a person, trust me, it shows. It shows in your voice, it shows in your language, it shows in your eyes. Um, it's a very hard thing to check your judgment at the door, but we have to. We have to when we do this work. We have to. Everybody has, I tell people, if you're not feeling some judgment, you're doing this wrong, because we are human. There are things that are going to trigger us and make us feel uncomfortable. If you're not feeling uncomfortable, you're doing this wrong. So it's okay if you feel uncomfortable, but really, like, I had to go through and like read up on like current language. Just take 5 minutes out of the day to educate, like, what should I use in place of addiction? How do people like to refer to themselves? You may have a client one day that tells you they like to be called a junkie. Go ahead and call it. They feel that they're comfortable. Some people take pride in the word. I wouldn't necessarily say keep using it. Try to offer them something else, but also don't try to with stigma, don't try to like be hip and use lingo, because I've seen that happen and it's not pretty, because people can tell that you don't. There's a difference between learned experience and lived experience. And some of the best harm reductionists I know have no lived experience. They have learned experience, but their learned experience has taught them to not try to pretend like they have lived experience. Really, biggest thing on here, offering people hope. Don't lie to them. Don't tell them something that that's not going to come true. Like, we're going to have a house for you by the end of the week and life is going to be beautiful. Because what's going to happen is people who have no hope and they begin to trust, they're going to take that at face value. And when it doesn't happen, you break that trust. And that, unfortunately, has already happened so many times with traditional service providers. And again, this is where EMS, this is so important. I wish there was EMS in the audience. Your language matters so much. The look on your face matters so much. Personal scenario right here. My partner had endocarditis over the summer caused by a tooth. She's a therapist. She was not using. Because of COVID, she didn't go to the ER. By the time we had to call emergency room, she was almost, that would have been a story I should have told, but I couldn't, because I would have absolutely lost it. When the EMTs came to our door, and what we had told them over the phone, I recognized it as endocarditis and sepsis. They came in expecting, the first thing they said is, "Oh, it doesn't look like junkies live here." That's exactly what came out of their mouth. And I said, "It's because they don't." And they looked at her arm and they said, "Well, how did she get it?" And I said, "Open her mouth." Because I knew it was a broken tooth at that point. Her tooth had broken 3 weeks before. But that's a scenario. So let's say that we were people who were using that language right there. Even if they thought that, they didn't have to ask that. They didn't have to come to my house and ask how we afforded a spiral staircase. That was literally a question that was asked as my partner was lying on the couch dying. That's horrific. I don't want anyone to experience that. Thankfully, I had the language to work through it and to not react. That's so simple. It's like, as we talk about Stephen Murray, I want people to read the next quote. And it was going to be for, I'm going to read it out loud actually, because Steve and I were talking, and this was a text he sent me, and I was like, could I please use that? Because I think everybody said that if we had one slide, this was the slide we needed. "We encounter people who use drugs in so many settings besides overdose, and many don't realize how stigmatizing the entire experience might be for that patient for the rest of the time they're there. Wound care, endo, myocarditis." Oh, there's a big word he used I wasn't ready for. "Issues obtaining medications, uncontrolled pain management, environmental emergencies, hypothermia for the unhoused," which we do see all the time, "are all scenarios we are seeing in our community. I always make sure that no matter what their experience may be after them, that I'm the one nice face." It's the most important thing in this, the one nice face they may encounter, no matter what, and then act as an advocate during the care handoff. If I convince the doctor and nurse how much I care about this person, I might be able to spark some additional empathy in them. I have found that our greatest asset is patient advocacy for those who are accustomed to being marginalized, and I take that role very seriously. Now, this is coming from a paramedic, but it applies to all of us who do service provision. If you can remember what I said at the very beginning when I introduced myself, what I found the first time I encountered harm reduction was a nice face, was a face where somebody actually looked me in the eyes. And like I said, I realized nobody had done that in months. I think it'd been close to a year. And because of that, like, and I'm very honest to say it didn't happen overnight, but I got into recovery. And I think had I not had that kind base, I wouldn't be sitting here doing this talk today. I would have been dead within the year. I know we're at 2:08. Wanted to leave a half an hour for questions. We have 22 minutes. And I want to thank everybody for allowing me to be so very vulnerable. People who know me will tell you that I don't cry. That's a lie. I cry behind closed doors. But there was a part of me last night when I got this call where I thought I was going to have to cancel this talk today because I was so emotional. And I think it was almost like fate. You know, there was a reason. I don't think there's a reason that John died so that I could talk to EMS, but it was very interesting that, and it was almost like he was above saying, share my story. And so hopefully somebody's going to hear it and change the way that they treat people who use drugs. So with that said, I'm ending and I'm opening up for questions.
Thanks.